Thank you, Rich. I'm delighted to be here. I always feel very much at home when I come to Bakersfield. When I came here 6 years ago, Bridge was the first one to introduce me to the community. There are many friends in Central Cardiology. There are others. Dr. Sam Singh is here. I can't name all of them, but when I get a phone call from one of them, I wake up because it's usually a very complicated issue. I'm towards the tail end, and all I can tell you is that I'm an electrophysiologist, and if you fall asleep, I'll defibrillate you. So let's just start at why this is an important problem. You all know this, but repetition is the spice of life. There are at least 300 to 350,000 sudden cardiac deaths in the US every year, maybe about 50 in Southern California every day. That should make us wake up a little bit. It makes up 50% of all cardiac deaths, but here's the problem. We try to get there very soon. We try to get 911 to operate soon. We use AEDs, we do bystander CPR, but guess what? Cutting edge USFA today, 7% is the survival rate from resuscitation. So anything you're going to do that makes a dent to sudden cardiac death really has to be prediction and has to be prevention. So it's one of those conditions. There's no human condition in which, Dr. Nalos will tell you that. There's no other human condition where once you get it, you die within 10 minutes. So keep that in mind. As we get older, sudden cardiac death becomes more common. Yes, it's a good way to go. It's quick, right? But look in the middle, look at middle age, look at that gray area. At least a third of all sudden cardiac deaths happen between the ages of 35 and 65. And I dare say there are many in this room who might fall in that category. Now, why is it so important? Well, in middle age, it turns out, in many it presents without warning. It happens every day, but it's the silver screen that really cries out to us. So whether it's Gandolfini or it's Russert, none of them had much in the way of warnings. Of course, maybe one had some risk factors beyond the other. But there's quite a variation, and many will present without warning. It happened at any age. Look at Ryan Shay. He was a hope for the 2008 Beijing Olympics. And he died while he was practicing in the 5th mile of his race. He wasn't even sweating at 5 miles. Ryan doesn't even sweat. But he had a sudden death. His wife was running in the same race. And to your right, it can happen in any age. There are young people, of course, we're lucky that these sort of devastating young deaths don't happen that commonly, but they do happen. So what are we going to do? So I'm just going to, it's late in the evening, Rich keeps talking about this wine, I hope it's good. And so I'm just going to be very sort of brief and be very clinical, and we can discuss more later. So we'll start with some causes, just to refresh our memory. We'll talk about what the guidelines say and how we deal with them. But I think I'd like to touch on some special situations because, you know, those are the ones that really tie us into knots at times, and then just summarize our overall approach to sudden cardiac death. Well, clearly the gorilla in the room is coronary artery disease. At least 80% of people who have a sudden cardiac death are going to have coronary artery disease. Well, there's a smaller but important iceberg closer to the tip, which is the cardiomyopathies. Now there's an overlap. You can have ischemic cardiomyopathy, you can have dilated cardiomyopathy, you can have hypertrophic cardiomyopathy. It's, after all, a disease of the heart muscle, so it's very broad. But the tip of the iceberg is very important. It's far more common in our clinics than it is in the community. But when these people show up, it really makes us listen, because some of these have, mostly they're younger, mostly they have hereditary disorders, and so I'd like to touch on them as well. Now, this is what you see in the cath lab. But in this particular situation, the patient was lucky enough to get to the cath lab. So here's the clot in the left main extending to the circumflex. But these two individuals on the right obviously were not as lucky. They ended up on the autopsy table. And the one on the top is your typical lipid-laden rich plaque. And the one on the bottom is a plaque erosion with a platelet plug. It could happen either way. And the reason I put this up is we are really, really very bad at figuring out which heart attack is going to become a cardiac arrest. So there are 100 heart attacks that might happen, but maybe a couple might be a cardiac arrest. So we really need to get our act together. We have really no idea which ones of these, right, will end up on the left and which ones of these will end up on the right. We are a little bit better at, this is another unfortunate individual. This picture was taken at a bad time. Because again, they had an infarct, but a big scar, and around the scar, the electrical impulse rotates and leads to this ventricular tachycardia that can become ventricular fibrillation. And we are more familiar and a little bit better at this, where you have a sick, baggy heart with scar. We say, okay, ejection fraction less than 35%, and yes, you might need a defibrillator. So we're better at the chronic presentation. And what do we do for that? The main modality for primary prevention today is the implantable defibrillator. It's a pretty clever device. In 1980, when it first came about, it was thought as to be very unnatural. It shouldn't be on center stage. Well, it's on center stage now. It's a main modality. And of course, as you know, this is actually, the picture is by Michelangelo and the device is by a company. And so the old masters were really knew anatomy. They could paint, but they knew anatomy. And so it's a DC shock that happens within 8 to 10 seconds of ventricular fibrillation or ventricular tachycardia. Of course, not just a shock. My partners here, Dr. Wang and Dr. Shah, are sitting here. They spend the whole day looking at this and teaching fellows. And the first thing we teach them is that the device can pace as well, and from a fast rhythm, bring it to sinus rhythm by overdrive pacing. But of course, this is an ECG from inside the heart, from the tip of the ICD lead. Here's a shock, and then we're back to sinus rhythm. So everything happens between 8 to 10 seconds. Follow-up has become quite easy, okay? We see them a month post-implant, and then we used to see them every 3 months, and I'll tell you why that has changed. Battery longevity is 4 to 6 years, hopefully getting better. The clinic visit has now become yearly. I don't think still that you can do this at home. Some people think that they might be able to. I often have patients asking me, can someone control my device externally? And I tell them that yes, but only we can. So there's this remote monitoring setup. We don't need to have patients with ICDs in Bakersfield. You have wonderful care in Bakersfield for this. But there are other parts of Southern California and other states where patients don't like to beat LA traffic. So we actually monitor them remotely quite commonly now, and it's easy to do. So that's one thing to keep in mind when you talk to your patient, that you might only have to see your doctor only once a year. Now, there's always the fine print. And I think it's incumbent upon all of us as specialists to talk about the fine print. We have to acknowledge that the primary prevention thought process, clinical approach is based entirely on the ejection fraction. But when you do that, only 5% of devices fire every year. And so in 4 to 5 years, only 25 to 30% of all patients who get a defibrillator actually fire their device or use their device. Most of them actually never get used. That's a problem, isn't it? Because you can look at the number of devices, and this stops at 2006 because there was no room on the slide, okay? The number of devices is increasing, but the number who fire, the proportion, still plateaued. So we've got a lot of work to do. Treatments in 20 to 30%, at least 20 we need to save to save one. We need to treat to save one life. You could argue that's not bad, but we'd say that's not really that good. We have to do a better job. And so it's important to follow the guidelines, but it's also important to enhance them. And as Bridge alluded to, at the Heart Institute, we have a sort of a special interest in this, and we follow a 1 million-size community in the state of Oregon. And as of the 10th of January, we are adopting Ventura County. So we have a sister project in Southern California. Who knows, Bakersfield might be next. But I think that we just have to be cognizant. As I talk to you, please remember that we need a lot of work yet to be able to enhance the guidelines. So I talked about the common forms. So coronary artery disease, most common form, EF less than 35%, defibrillator, cardiomyopathy. So they look pretty ugly. I mean, when you look at them after death, anything looks ugly. But here's a dilated cardiomyopathy. Here's typical hypertrophic cardiomyopathy, very thick left ventricle. Here is a condition that we call affectionately ARVD, but it's really a long word arrhythmogenic right ventricular dysplasia, where the muscle of the ventricles is replaced by fat. So if you shine a torch, the light comes out at the other end. Wherever fat ends up is bad. So in the heart, it leads to arrhythmias because it's a poor conductor of electricity, causes barriers, impulse goes round and round, causes ventricular tachycardia, ventricular fibrillation. So these are all pretty ugly disorders. So how do we deal with them? Well, they come in all shapes and sizes, but this is just one slide to show you that a lot of these genes are related and they code all these proteins that are on the membrane sometimes or inside the cell of the heart. And they do things to the ECG. So this beautiful looking ECG, the QT interval might stretch out because the electrical signature inside the cell is stretching out. So here's an example of long QT syndrome. Here's another example of a rare disease that as an example, I'd like to focus on because it may be the more common of the rare diseases. And obviously this is hypertrophic cardiomyopathy, absolutely. High voltage, classic. Do the echo, you'll find it. But the gold standard has become the MRI. And I'm just going to put one slide of the MRI because I think this is absolutely fantastic, that you can have imaging that can teach you something different about the natural history of a disease that you had no idea about. So we used to think it's all asymmetric left ventricular hypertrophy. Well, it's like anything under the sun. You can have it like this, classic asymmetric. You can have it on the septum. You can have it looking towards the apex. So we have really changed the way that we think about hypertrophic cardiomyopathy. It can even be severe concentric hypertrophic cardiomyopathy. But all of them carry some risk. The beauty is the risk is not that high. So how do we risk stratify a relatively rare condition, still not uncommon in our clinics, like hypertrophic cardiomyopathy? So we take the evidence, we put our heads together, and the summary is on this slide. If you look at, because the disease is so complex, we couldn't just say numbers 1 to 4. We had to say major, we had to say minor, and we had to say modifiers. It's just a reflection of the complexity of the disease. It runs in families, and very often we find genetic mutations by standard commercially available tests. Still, if you notice, we use clinical features to decide prognosis. So the major criteria are, of course, that's a no-brainer. If someone in the family had a sudden death, that's considered very high risk. If you had unexplained syncope, the S word, we deal with it, in a very agonizing fashion. It's the difficult one. And of course, massive left ventricular hypertrophy, like 3 centimeters or more. Non-sustained VT on the Holter, okay, maybe. Abnormal blood pressure response with exercise, we used to hang our hat on that, we don't anymore, okay? How about modifiers? Obstruction, okay, do a myectomy. Gadolinium on the MRI, more to follow, not enough data yet. LV apical aneurysm, okay, could be, and genetic mutations. The only way today that tests really help are if they're negative. So it is quite important to actually consider genetic testing for that very important reason. You have children, you have relatives. If you can have a genetic test that's negative, that's absolutely fantastic for that individual. So what else do you do? Here's just an example, and this cuts across a bunch of these relatively rare syndromes. Modification of physical activity, that's really very difficult. At the Heart Institute where I sit, I often get these people who come shopping. They're elite athletes at times. They'll go to one electrophysiologist, go to another, until one will say, okay, you can play. And so it's a very, very difficult thing. And you have to sit down with these young people and their families and really actually do some psychotherapy along with some clinical approaches. It's very, very challenging. And then sometimes you make a compromise. You say, listen, you're a fantastic basketball player. Have you ever tried golf? It doesn't work very well. You have to try. So, excuse me. I've had some of my patients play tennis, but tennis doubles is allowed. But really, we have to be careful about, on a case-by-case basis, about intense competitive sports. But I think what the message I want to give you is really, if you have one of these people in your clinic, you come across them, If you have experience with them, that's fantastic. If you don't, send them to a cardiologist who knows the condition and is kind of used to looking after those patients, or to an electrophysiologist who's familiar, because it really requires sitting down with the patient, but also with their family. And so what really we've been driven to do at Cedars, because we didn't have a choice, is we've created a cardiogenetics program. And the glue that binds the cardiogenetics program is a full-time genetics counselor. There are a bunch of us who actually see these patients, but the genetics counselor is who kind of puts all the action together. And so this is an example in cardiology. I mean, I think that I would agree with people who say that personalized medicine right now is not ready for prime time. But this is a set of conditions, the relatively rare arrhythmias that are familiar, where you can actually have a personalized care plan. Why is that? Well, you've examined the patient, you've evaluated them clinically, you can do a commercially available genetic test, there are a bunch of these out there, and insurance reimburses them. And you can extend these findings to the family members. And so this becomes really important. So if you have one patient, that's not the end of the story. I thought that I should also touch on exercise, because this is a question that we're facing increasingly. As cardiologists, we face this all the time, but I'll show you why it's becoming more and more common. We learned about 20 years ago, there were some really beautiful studies that were done. There were 3 or 4 of them that actually showed that, especially in sedentary individuals, during the time that you exercise vigorously, your risk of sudden death goes up. And when you stop exercising, after a little while, the risks come down. Okay? It increases by 56-fold in people who don't like to exercise. However, for those of you, and there are many here who I think are keen on exercise, this risk increases only by 5-fold if you're habituated to exercise. So big difference. You can already tell that if you're habituated to exercise, that's a good idea. In fact, if you exercise regularly, even just mild to moderate intensity, there's nothing wrong about exercise. So it decreases your risk of sudden death. And it decreases your risk of myocardial infarction, not just sudden death. So leisure running, even at slow speeds, is fantastic. Now, why is this becoming an issue? So our clinics are filling up with people who never want to die. And this graph will tell you why. If you look from 1990, these are the running event finishers. These are people who have run in long distance races. And look at the numbers. It's not just men, it's women too. Okay? So the number of people who are older and older, okay, and as I get older, I'm not even going to define what old age means, but I think that the numbers are increasing. So the population at risk, even though it's a small problem, the population at risk is rising, and we really have to answer this question in people at middle age. So how do we prevent sudden cardiac death in the older athlete? This is sort of the special situation that's becoming a common situation. So I would say this is like one slide that kind of summarizes what I want to say. The mechanisms most commonly are probably plaque rupture. On top of the list, there are some rare disorders like hypertrophic cardiomyopathy we talked about, etc. But in the middle-aged athletes, it's mostly coronary disease, coronary plaque rupture. But we don't know which plaque rupture leads to VF. That's the problem. Some people say that as I'm talking to you, I have plaques rupturing and repairing all the time. I don't like that kind of vision. But I think that what we need to know is, which plaques rupture and lead to ventricular fibrillation. So there's this transiently increased risk. But you have to balance that with a beautiful protective effect of regular activity. So you can't stop regular activity. Dr. Makar told me that he's really hitting the gym these days, and it's showing. And if you look at the habituated athlete, you don't really have to, thank you very much. You don't really have to worry too much. But if they want a significant, so if they're running 3Ks or 5Ks and they want to run a marathon, you want to pay attention to them. But for the athlete that comes to you who's sport naive, it becomes really important because they'll say, hey doc, I feel very young. I know how old I am, but I feel very young. How far can I run? And can I do this like Long Beach half marathon? A bunch of people come to me like that. And so I think that if you just take the literature and you try to synthesize it, you can have just a simple 3-step screening process. There are patient questionnaires that the AHA has published, and I'm not going to bore you with long questionnaires, okay? But basically they deal with symptoms, clinical history, family history, and you screen the patient with their questionnaire, and if you have 1 or 2 things they check off on the questionnaire, they come to the physician. And really what the physician can do is an EKG and a submaximal stress test. There is no proof for anything else. And actually, even with that, you're going to get subocclusive disease. You're not really going to catch the 30% plaque that doesn't rupture. But that's the reality of life. And how to mitigate risk? Well, next they ask me, well, how can I decrease my risk? Well, the first thing I advise is a gradual increase in activity. So take 6 to 8 weeks, if you're non-habituated, to actually get from walking to running 2 miles. Take your time, and your speed doesn't matter, because the benefit is the same. I think that there's enough data for aspirin, but I don't think there's enough data for, say, a statin, unless you meet standard indications. Okay. So that really is sort of like the balance between this risk that we have, the population at risk that's increasing, and then the protective effect of regular activity, so we can all look like this. Now, how many of you recognize this is Dr. Bambi, who was captured at the LA Marathon? And the picture is kind of a blur because he was going so fast. So lest you think that your cardiologists don't practice what they preach, I felt that I should put this picture up. But I know who his role model is. This is Chugh Singh, the Human Torpedo. And this is where Dr. Bambi wants to be when he's 103. Now, there's one problem with the entire situation, and that is when you talk to Chugh Singh, you ask him, what's your secret, Mr. Singh? And he's called the Human Torpedo, and he's very measured in how he talks. He says, I'm totally vegetarian. I only eat some dal, some chapati, and some nuts. And nothing but water crosses my lips. So it remains to be seen that whether there's no Cabernet here, there's no single malt. So let's see if Dr. Bambi goes completely like Chugh Singh. So what do we do? What do we do with patients today? And this is just the last few slides. And I just want to sort of think aloud with you. You know all of this, but just to revise it. So today, I think the best we can still do is keep up our resuscitation skills. Everybody should know CPR, right? And we're learning that in addition to getting there quickly, because time is myocardium, we need bystander CPR. We all need to know how to use the AED. And there are these fantastic people out there in the fire department, the EMS system, who actually do an amazing amount of work and take care of us. And so early access, early CPR, early defibrillation, early to the cath lab. All of these are things that we can do day to day, right? Well, we can't change our genetics, I'm afraid, not yet, okay? But we can't forget about the modifiable risk factors. If 80% of people have coronary disease, if you decrease the progression of coronary artery disease, like Dr. Shah said, well, your AFib will come down and your sudden death will also come down. So smoking is a no-no, of course. High blood pressure, we have to work on. We've got to work on our lipid profile. This is becoming a huge problem. A third of the nation is obese. Physical inactivity, we talked about diabetes, also very huge problem. And psychosocial factors, since we can't measure them, we're scared of them. But when we talk to our patients, we know their factors. So this is something that we have to think about as well. So let's summarize briefly this sort of clinical approach. I think that I hope I've convinced you that sudden cardiac death is still quite a problem. We still have to work on it. Coronary disease is the major player, but there are other etiologies, and sometimes they're harder to sort out than coronary artery disease. The nature of this condition makes prediction and prevention very important. I mean, unless we work towards it and do a better job, we're not going to get anywhere. For common coronary artery disease related sudden cardiac death, primary prevention is based on the ejection fraction, and you're going to reach for the defibrillator, but follow the guidelines. Rare forms relatively rare forms are going to need referral, and don't be shy to do that, because it doesn't affect that patient, it affects their family as well. Broad screening, I didn't really touch on young athletes, but broad screening is not cost effective and it's not helpful. I hear about people saying, oh, I'm just going to go to this high school and do EKGs on all kids. That's never been shown to be helpful, okay? Especially in the US. There's some countries where it seems to have a benefit. Use a systematic approach. Older athletes are going to come to you. You might as well be one of them. So keep CPR, AED, basic prevention in mind. And in the future, what we're really hoping, a lot of us working together, will be able to enhance these approaches. Because really, we have to change the guidelines. They almost become like legal documents. And we're in that process. We'd like to do that. And all we need to do, and it's a big task, is to identify the patient who's most likely to benefit so we can actually pay for our healthcare. Thank you for your attention.